Hello, everybody. In the interest of time, we're going to get started. My name is Katerina Dukleska. I'm a pediatric surgeon at Connecticut Children's, and I am privileged to co-moderate this session with Mike.
Hi, everybody. Dr. Mike Livingston from McMaster Children's Hospital and the chair of the Practicing Surgeons Subcommittee. I'll turn it over to Dr. Dukleska to introduce the first abstract.
Okay, we're going to get started with our first abstract regarding Dr. KASAI with Dr. Dumitru. We'll have you come on up, please.
All right. Good morning, everyone. Oh, thank you. Is this the quick advance? Yeah. Okay. I wanted to thank the organizers for giving me the opportunity to speak to you today and to start out this session with a brief historical overview, talking about one of the legends in pediatric surgery, Dr. KASAI, and the title of my talk is Beyond the Hepatic Portoenterostomy. In terms of disclosures, I thought this was a good representative image. As far as trainees, we have the structural capacity to receive disclosures, but nothing inside. So this is a piece of art that you'll notice in San Diego. It's actually a couple blocks over, so if you're walking around later, you might see it. So Dr. KASAI is probably best known for his contributions in the realm of biliary atresia with the hepatic portoenterostomy procedure, which bears his name. And I know I'm talking to a room full of pediatric surgeons, so the purpose of the diagram is not to illustrate to you how this procedure is done. It's for the trainees in the audience who maybe are not as familiar with this. But in terms of his legacy and his contributions, prior to the advent of the KASAI procedure, the mortality associated with biliary atresia was nearly 100% by the age of 2. After the advent of the KASAI procedure, and now with the subsequent liver transplant that these children undergo, the survival to adulthood is it's the majority. It's almost 90% of children who undergo this procedure then go on to adulthood. So I think this illustrates the impact that a person can have in surgical innovation and just in changing outcomes for children. And it's part of what motivates, I think, all of us here. Beyond biliary disease, Dr. KASAI was a very thoughtful individual who had a wide variety of intellectual interests, and he made contributions to the surgical management of Hirschsprung's disease. This is a diagram taken from one of his sketches that he designed for infants that came to his practice who were, he thought, too small for the traditional Swenson pull-through. And so he designed a rectal myotomy and colectomy as an adaptation for those infants who were too small to undergo that procedure. He later refined the procedure with a rectoplasty and a posterior colonic flap, and that's what this diagram is showing here. He made a number of other significant contributions to the field. He came up with one of the early classification systems for pediatric hepatoblastoma. He made contributions in terms of fluid management in the perioperative and postoperative period. And he was an early advocate for procedures for esophageal cancer that weren't just palliative, and he designed a jejunal interposition for esophagectomies. Outside of that, I put Dr. Koop on here. Dr. C. Everett Koop was a former U.S. Surgeon General, as all of you know, and Dr. KASAI actually trained under him. He did a fellowship with him early on in his career. And at that time, at least from my reading, it is my understanding that Japan didn't have a separate pediatric surgery department. And after his training there, he came back and was one of the influential people in kind of designing that. He then went on to receive a number of awards. He had a very prolific career, and he received medals such as the William Ladd Medal. And interestingly, Dr. Koop was around for that and was able to present this medal to him. They had a lifelong friendship, and he was a mentor to him. And outside of that, Dr. KASAI was known as a community builder. He spent a lot of time advocating for the importance of in-person meetings locally, nationally, and internationally. And he was known to enjoy sake with friends as well, and was an avid skier and mountaineer. This is a picture in the bottom left of the screen that was one of the tallest mountains. It is the tallest mountain range in Tibet. And he led a group that was the first to climb this mountain, actually, apparently. So that's pretty remarkable. And I think overall it's a good way to summarize his life was a series of climbing a lot of mountains. This is an image from the Aomori Prefecture in Japan, where he came from, and I think it reminds us of the different mountains we all climb every day and the opportunities to make a lasting impact on this field. So with that, I'll take any questions, or if anybody in the audience perhaps knew Dr. KASAI and wants to share anything.
I'm looking around the audience, Jeffrey Lucas, Washington, D.C. But it's a fascinating story and it's a fascinating rendition. I think it's important to note that when Dr. KASAI initially came to CHOP, he and Coop developed that relationship. And then he went back to Japan, but the real translation of that operation came to America much later than it had been performed in Japan. And KASAI came back to America in 63, 64, and he really worked, which I think is important to mention in this, Louise Snoffer. Dr. Snoffer and he did over 100 KASAIs during the 63, 64 era. And she was really trained to several pediatric surgeons that then populated the East Coast and then went west to Denver, where Starzl and everyone was. But that's the true history of when he came back and extrapolated that operation to America. It was Dr. Snoffer.
Okay, we'll move on to the next abstract. Again, congratulations on your work.
Okay, thanks so much. So we're going to change gears now a little bit and do a case-based discussion on the management of choledocholithiasis in children. As I mentioned, my name is Mike. My co-moderator, Dr. Katarina Dukleska. We also have a working group, which includes Dr. Brian Gulak from Rush, our resident representative, Dr. Mary Froelich, Dr. Irving Zamora from Vanderbilt, and our education committee chair, Dr. Eunice Wang. So at the end of this panel discussion, our hope is that attendees will be able to describe the screening and workup of choledocholithiasis in children with symptomatic gallstones, to articulate the indications, advantages, and disadvantages of IOC, MRCP, and ERCP in children, and identify which patients with choledocholithiasis are good candidates for transcystic laparoscopic common bile duct exploration. To make things more interactive, we've assembled an expert panel of pediatric surgeons who have an interest in choledocholithiasis or who have published on this previously. Dr. Cynthia Downard, a professor from the University of Louisville and the surgeon-in-chief at Norton Children's Hospital. Her group has published on their experience managing choledocholithiasis and really emphasizing the use of IOC and attempts to minimize non-therapeutic ERCPs. Dr. Romeo Ignacio from Rady Children's Hospital, clinical professor and a investigator on the SAGES guidelines on safe laparoscopic cholecystectomy, which is an effort to reduce the incidence of common bile duct injuries. Dr. Ignacio is also the principal investigator of an ongoing multi-center study looking at the management of choledocholithiasis in children. So I'm not sure if he's going to give us any sneak peeks, but we will definitely be looking forward to those results. Dr. Lucas Neff from Wake Forest Baptist Medical Center. Dr. Neff has published on transcystic laparoscopic common bile duct exploration in children, and his group will be sharing an abstract on that topic following this discussion. And Dr. Bethany Slater, she's the chair of the SAGES Guideline Committee, and we'll be referencing some of those documents in this discussion. So first case, this is a patient from my clinical practice. So full disclosure, if you think anything is off base, you can direct those criticisms to me. This is a 14-year-old girl with biliary colic, comes to clinic with a 6-month history of intermittent abdominal pain, no jaundice, no dark urine, has a history of anxiety, but is otherwise healthy. Her outside ultrasound shows mobile gallstones, no intrahepatic duct dilatation, and a common bile duct that measures 6 millimeters. Her serum bilirubin is normal, but interestingly, GGT is 3 times the upper limit at 97, and her lipase and liver enzymes are all normal. So first question for the panel. How would you manage an outpatient with biliary colic and an elevated GGT on screening blood work? MRCP first, ERCP first, elective laparoscopic cholecystectomy only, elective laparoscopic cholecystectomy and IOC, or elective laparoscopic cholecystectomy, IOC, and possible laparoscopic common bile duct exploration. So maybe we'll start with Dr. Slater. What would you do in your own clinical practice?
Well, I would go with C, without having reviewed the literature very extensively in this subject. I typically will look mostly at the T-bili levels and the common bile duct on ultrasound.
Anybody else on the panel who would do, anybody else on the panel who would do differently?
My option's not down there, but it depends on the context here. Your scenario is fairly straightforward. However, some of us actually will observe them. You know, if their pain goes away and their LFTs are trending downward, I would definitely agree with that. However, if this is someone who's having persistent pain and your trend is going upward, that's a different story. So it just depends upon the context, but I agree with Bethany. So.
Yeah.
Dr. Neff.
Lucas?
Is this working? Yeah, it is. Don't need to push it. Yeah, I guess the question is, when were those labs obtained? Is that something? I mean, usually we're getting these patients from PCPs that have already done part of that workup, but then there's this temporal situation where you've got labs that may be outdated by several weeks, and do you repeat those? Do you not? I mean, I would favor probably moving forward. I don't really pay a lot of attention to GGT. Maybe people can throw tomatoes at me for that, but I would have all options on the table, C, D, and E, you know, in terms of just having that skill set and being comfortable with doing everything. You can certainly shoot a cholangiogram, and it's a great thing for trainees, but also if you need to take the next step and intervene on the duct, if you find a filling defect, then you can do that as well.
Is what's pushing you is the GGT or the dilated duct, or what exactly is driving you to your decision?
Well, that's why I said C, primarily to follow Dr. Slater, but just the point being that if you have the tools in the toolbox, which I think everybody in this room probably does, then you have the entire C, D, and E options available to you.
Anybody in the group does cholangiograms, intraoperative cholangiograms routinely? I don't, but just curious what the...
I do if they're straightforward. In this particular situation, we would be set up to do that, but if it's a struggle at all or the duct doesn't look amenable to that, I wouldn't try too hard.
Great. So a brief review of the literature. If you look at the SAGES guidelines on this topic, again, adult data, adult literature, but very relevant to the adolescents we often see with this. They identify 4 main risk factors on preoperative imaging and blood work. So stone in the CBD and ultrasound, common bile duct greater than 8 millimeters, presence of clinical cholangitis, and a serum bilirubin greater than 1.7. So if you look at these factors and you add them up, if you have 2 or more, you're high risk. If you have 0, you're low risk. The intermediate, they actually don't specify. They say somewhere between those two. They don't say, what exactly would put you in that range, but it identifies that this is an area where some clinical judgment and experience has a role. So our patient would actually be low risk. And if you look at that, what that means in terms of management, as mentioned by our panelist, laparoscopic cholecystectomy is quite reasonable. For intermediate risk patients, IOC is an option. They note that MRCP or endoscopic ultrasound can be done, but then elsewhere in the guidelines they point out that this certainly can add to costs and delays in care. I've never seen or heard of a child or adolescent undergoing an endoscopic ultrasound, but depending on your practice environment, maybe that's something you might see. But in my mind, if you had an intermediate risk patient, I would be avoiding pre-op MRCP or endoscopic ultrasound when possible and defaulting to IOC. There are other guidelines out there, so particularly if you're asking your adult GI colleagues for ERCPs, maybe not in this patient, but in other patients, they may refer to this document, the guidelines from the American Society of Gastrointestinal Endoscopy. So very similar risk schema where you have low, intermediate, and high-risk patients. But interestingly, any patients who have elevated liver enzymes or any biochemical abnormalities fall into this gray intermediate group where you'd be considering doing an IOC. What about pediatric patients? This is a really nice study using pediatric-specific data, and there's not a ton out there. This is 316 children who underwent either IOC or ERCP. The predictors included elevated ALT, ALP, total bilirubin, and then CBD diameter and ultrasound. So they didn't create a specific point system or scoring system like the other guidelines, but they did note that these factors were more specific than some of the other factors in the ASGE guidelines. So if anything, showing that abnormalities in liver enzymes may be something to consider. So there I am sitting in clinic trying to figure out exactly what to do. I thought that the patient might be intermediate risk because of the elevated GGT. But I felt a little uncomfortable because this is a patient who did not have health insurance. Even though in my practice environment in Canada, we have universal health coverage, there are faith communities that decide to not participate in that. And so their community really pays for all their healthcare costs. And so I was trying to be as evidence-based as I could, but with these borderline gray cases, it sometimes is a little tricky. After talking about all the different options, we ultimately planned on a laparoscopic cholecystectomy and IOC as a day procedure with no plans for admission overnight. This is a cholangiogram not in that same patient. This is actually one of Dr. Ducleska's patients, but it's a really nice picture, so that's why we used it. And just pointing out the structures, there's a cystic duct, common bile duct. It's mildly dilated in this picture. Contrast seen in the duodenum, and then there's a filling defect distally. So maybe Dr. Ducleska, since this is your picture, comment on why this is an adequate IOC and what kind of things you look for when doing this.
So I think when doing an IOC, it's important to look for a few things. So an IOC can be helpful in not only helping you determine choledocholithiasis, but whether or not there's a presence of any injury or aberrant anatomy, which can sometimes happen. The other things that I look for are whether or not there's filling of the duodenum, which in this case, there's really a paucity of that. And looking to make sure that there's good opacification of the right and left hepatic ducts. Another thing that I think is really interesting is opacification of the right sectoral duct, which if I don't have a pointer to sort of point, but if you can imagine what the right and left hepatic ducts are, what's sort of almost at the tip of the Maryland is the right sectoral duct that's sort of opacifying. So that's one of the things that makes a good cholangiogram that you're able to see into the liver. And this patient actually, in particular, responded well with just flushing and glucagon administration.
So meanwhile, up in the Barrens of Canada, I tried the same thing, glucagon 1 milligram IV. I think it is important, if you even think there's a small chance that that you're going to need to do this, to talk to anesthesia to make sure that they have that medication available. Because if you have to run down to inpatient pharmacy, that can be a significant delay. Waiting 2 minutes, I tried flushing the catheter, but did not have the same luck as Dr. Ducleska, unfortunately, and the defect persisted on repeat IOC. So question number 2 for the panel: how would you manage a patient with a non-obstructing gallstone in the CBD on intraoperative cholangiogram? Complete the cholecystectomy alone, complete the cholecystectomy and trend blood work postoperatively, attempt a transcystic exploration, attempt a transcholedochal exploration, or complete the cholecystectomy and plan for post-op ERCP. Maybe we'll start in the other direction. Dr. Downard, what would you do in this situation in Louisville?
So we are very fortunate in Louisville to have really world-class endoscopists who are surgeons. So ERCP is relatively easy for us to obtain, especially in adult-sized patients. We would typically complete the cholecystectomy, trend the labs, but involve our adult surgical oncology colleagues who do ERCP, and they'd be following along with this. Usually results in an ERCP in a day or two if the labs don't get better.
And is there anything differently you do in terms of completing the cholecystectomy? Do you use more clips? Do you Or you just do sort of your routine practice?
Just routine.
So I'll jump in. So to answer the very last question, I would, if I was unsuccessful or I knew that there was an obstructing stone that remained, I would probably put an endo loop on. That's what I typically do in addition to my clips. Just it makes me feel better about that. I think that to treat this patient, I would certainly try to get a wire down and either power flush at the source of obstruction using a through-lumen Fogarty, or go in with nitinol baskets and try to extract that transcystically under fluoroguidance. The reason being that if you can even break that stone up, especially with a nitinol basket, then that's going to make it a lot easier to flush through. And there's not a whole lot of downside. I think people are a little bit nervous about injuring the duct or doing something. But again, I guess my main message to the group would be that the skill sets to do these types of things are well, I mean, we all have them. And especially, with our practice getting vascular access in really difficult patients. So I would take a swing at a transcystic common duct exploration. I think the threshold to go transcholedocho is way too high when you have ERCP as a backup.
Yeah, I guess for the rest of you, is there anybody who would even consider doing a transcholedochal, or is that something in the past? Okay, great.
I'm curious in the audience, how many of you guys have the capabilities like Dr. Downard, where you have someone who can really help you to do that in an expeditious fashion? Just raise your hands. That's a lot more than I thought. How many of you have done a laparoscopic common bile duct exploration in the last year? Not as many and stuff. So it just tells you the difference of our resources for this particular problem. Thanks.
So that leads us just to the next question. Which candidate patients are good?
I think Dr. Hiroshi has a.
Oh, sorry. Yep.
Shinrosi, UC Davis. An option that we use is actually in that situation when we fail the lap common bile duct exploration to have the ERCP guys come to the operating room when we do the ERCP under the same anesthesia.
And is that's something you set up ahead of time?
Yeah.
Yeah. Great. So leads to the next question, which is which patients are good candidates for transcystic common bile duct exploration, if that is something you want to do, as Lucas was mentioning. There are guidelines on this also from SAGES. One way to sort of think about this, especially if it's not something that you do routinely and you want to start doing it with maybe an adult colleague or another pediatric surgery colleague, is remembering what the relative contraindications are. So if the cystic duct is narrow, friable, or perhaps even particularly tortuous, and it's going to be difficult to get a catheter down. CB stones that are large, multiple, or very proximal in the duct, and then lack of technical skills, experience, or equipment. I think we need to be honest. If we haven't, like myself, I hadn't done this in sort of 5 years, and I really didn't feel comfortable embarking on that. I hadn't talked about it with the patient and family ahead of time. So, being honest about that, I think, is important. The guidelines note that bile duct exploration can be performed safely in children, but the data on transcystic exploration are still limited. So getting back to the case, I didn't want to undertake this, so I did the cholecystectomy, as was mentioned. I work in an institution that has excellent access to ERCP with our adult GI colleagues. We did do an ERCP the next day, and a single stone was retrieved, and they went home the day after that. So 2 anesthetics, but at the same time had to stay in hospital. That was 2 nights only.
Did they leave a stent? Because then it actually leads to a 3rd anesthetic.
They did not leave a stent, and that's a really interesting comment, because I would say in our group they'll routinely do a sphincterotomy and a sweep, but they will very, very rarely leave a stent.
Dr. Slater, one thing that I'm curious that they've talked about in adults and performing sphincterotomies is that there's a potential risk of development of cholangiocarcinoma with sphincterotomies because of chronic inflammation to the bile duct. Has anybody looked at that in any significant way that you know of with your involvement in SAGES?
Yeah, it's a good point that has been brought out and commented for the adults, but I haven't seen anything in the peds literature regarding that.
Even with the absence of data on that, even throwing that out there as a little nugget when you're talking to GI doctors, because especially with these transcystic bile duct exploration techniques, they keep going back to pancreatitis. But I mean, that's a known risk, but at the same time, that data is a little bit shaky. And so you could throw cholangiocarcinoma back at them.
So I'll present the two subsequent cases. This next case is a 15-year-old boy with a history of sickle cell disease. He has had multiple previous admissions for pain crises, but only over the past couple of months he's developed intermittent abdominal pain. The patient recently presented to the emergency department with a 12-hour history of just persistent abdominal pain that did not resolve. While in the emergency department, his workup included an ultrasound that demonstrated numerous gallstones in the gallbladder, no intrahepatic ductal dilatation, a common bile duct that measured 5 millimeters proximally. However, they thought they saw a 6 millimeter gallstone somewhere in the mid-common bile duct. The patient's labs demonstrated a bilirubin level of 2.1 and a direct bilirubin of 1.5. His lipase was also slightly elevated at 121. So this patient, we admitted them to the hospital for intravenous hydration and pain control. His abdominal pain did resolve, and his repeat blood work demonstrated just improvement in all of those lab values. So a total bilirubin now 1.4, a direct of 0.4, and a lipase of 35. So the question that we have for our panel is, how would you manage choledocholithiasis in this patient with hemolytic disease? Would you just proceed with performing a laparoscopic cholecystectomy alone, an MRCP before any decision about surgery, a laparoscopic cholecystectomy and an IOC with a lap chole and a possible transcystic common bile duct exploration, or a preoperative ERCP followed by a laparoscopic cholecystectomy? So, really,
Start with my answer. In my institution, it's the practice that GI is consulted on these patients, sometimes even before we are as pediatric surgeons. And the GI's practice is to always do an MRCP on these patients to theoretically avoid the need for doing a preoperative ERCP that's unnecessary beforehand. So that's what's done.
Anybody else want to share there?
It just depends on when we're consulting. If we're consulting this patient, I'd probably do a lap chole with IOC. I have a big bias, obviously, because I think when we look at the criteria for choledocholithiasis, we are using adult data. That doesn't make any sense. If you look at some of the literature out there, we clearly need to have a multi-center study to look at these numbers. I'll present that at ACS that looks at some of those numbers, because a lot of the factors that we're using today are GI colleagues are using that, and that's not accurate numbers because they're reliable on adult patients, not on pediatrics. The second part is this MRCP business. We have lost control of that. That has gone to the GI folks, and all of you have had patients who come in on Friday, and they're going to want to do an MRCP, and they're going to stay the entire weekend until Monday, and that drives us crazy because depending upon your feel of it, it's a low risk or high risk or whatever, and again, those categories are a little bit gray for pediatrics. I think that there's a role for us to decide when is MRC truly needed, like for the intermediate risk, but for the high risk and low risk, even the high risk patients, a lot of our GI folks are sending for MRCPs, and if there's a 95% chance of having a stone, and you see a stone on the ultrasound, I mean, we should just go and take care of them, and just take that out of the equation. So I'm sure Lucas has comments.
Sound like a broken record, and I'll stop advocating for transcystic exploration. But what I would say is this: doing the IOC and making that your diagnostic modality as opposed to an MRCP makes so much sense. And the reality is that the GI docs, are much quicker to intervene with the ERCP, at least in our institution, after you bring them the patient with the cholangiogram that shows there's an obstruction. Like, let's get this done. So the idea of a preoperative ERCP, I think that just slows everything down. It should be, let's go to the OR, we'll do our diagnostic modality, we will either intervene on the stone or not, we'll take the gallbladder out, and we'll consult GI for the ERCP afterwards. This should be a surgeon-driven process, I think, and that, in our data, and this is some data that will be presented in a little while, we see that we're getting kids out much, much faster from the hospital. And the administrators love that as well.
The other thing is this patient's a sickle cell patient, and we all know the risk for anesthesia for these patients. And now you've done 2 anesthetics. If you could minimize that, I think that's a more important part. So, March.
All Right, two things. One of the instruments that you could use for your intraoperative cholangiogram is an arrow catheter, which I think is like super easy to manipulate, and it has a balloon at the tip of it, so you don't have to look for which vascular Fogarty is available in your OR, which is in a pediatric OR is difficult, but it's an arrow kit. You know, you direct it, it's easy, and then, you know, it secures it, and then you're like, oh, there's a stone, push it, and then pull it, and all is good. So number one. And then the other thing, the unfortunate thing, like just now presently, you guys know that there's an IV contrast shortage, right? So just let you know that I don't know what the impact is, but we're taking aliquots of our IV contrast solutions for the OR. So that might impact it depending on how many more shortages we have and for however long. I have no stock in arrow, by the way.
Thank you for that comment. So this patient, the SAGES guidelines that we've been talking about would say that, you know, he had a stone on the common bile duct on ultrasound, but the common bile duct diameter was not greater than 8 millimeters, and clinically he did not have any symptoms of cholangitis. But his bilirubin on presentation was greater than 1.7. So this would put him actually in the high-risk category. So this patient actually proceeded to a preoperative ERCP, and the adult gastroenterologist, just to top it all off, did request an MRCP prior that again showed just mild dilatation and possible choledocholithiasis. And an ERCP was performed 3 days later because it was one of those Friday admissions, and on the patient's ERCP, just demonstrated a normal common bile duct, and there's essentially, they did a cholangiogram that did not demonstrate any stones. The patient then did not have any abdominal pain post-ERCP with a plan of, proceeded with a plan of performing a laparoscopic cholecystectomy. Did well during surgery, did remain in the hospital for a couple of more days for pain control, and was discharged home 2 days after surgery. So in just reviewing the literature a little bit, this sort of answers this question. This is a great paper, and we're happy to have Dr. Downard here to represent and to discuss this paper as well. But one of the things that they described was the rate of choledocholithiasis, so which was around 20% in the pediatric population. So I think that this is something that's more common than we may even recognize. In their paper, they subdivided patients between low and high risk categories and used the size of the common bile duct to determine whether or not the patient was in the low or high risk category. In patients in the low risk category, recommendation to proceed with an IOC and during a laparoscopic cholecystectomy versus patients in the high risk category, recommendation to undergo ERCP. Dr. Downard, is there anything that you'd like to comment regarding this?
No, I do think, and I didn't comment on what we would have done with this patient, but we probably would have done an ERCP preoperatively.
And what I think everybody on the panel here would like to highlight, and this was sort of echoed in this publication as well, is avoiding MRCPs due to the added cost. Additional just publications that have looked at this have assessing the use of ERCP versus performing concomitant laparoscopic cholecystectomy for patients with choledocholithiasis. In this particular publication, 14 patients that had an ERCP plus a laparoscopic cholecystectomy during a single anesthetic, which is possible in some institutions, whereas 42 patients were treated with a preoperative ERCP and a laparoscopic cholecystectomy after. Found that there was a decreased cost in patients with a single anesthetic and no differences in complications, length of stay, or total anesthesia time. In terms of the recommendation, in this publication, they talked about how the practices are changing and evolving with the increased use of a laparoscopic common bile duct implementation, which is sort of even the hope of our session here today.
Can I ask, for those who have experience with that, as far as the difficulty with the insufflation with the ERCP, does that obscure the view at all with the laparoscopic cholecystectomy?
Are you saying does the transcystic exploration make the
No, if you have a ERCP and then laparoscopic cholecystectomy at the same setting? Did I misinterpret what was
Oh,
on the
yeah,
slide
no,
here?
so
I'm just thinking if you have the bowel very insufflated, does it make it more difficult to do the laparoscopic cholecystectomy?
We don't let them put the endoscope in until the gallbladder's out.
Yeah, I'm Mark Reiner from Dallas. That was our institution. So so we usually wait until like gallbladder's tethered on a string and you got your view and you got the whole thing and you're in a position where you could do the exploration if you wanted to, and then either you've already separated or you have them ERCP like during, so the complex part of the operation is already done. So that part hasn't been a big issue. I just got it here because I wanted to say that, so I've kind of had it both ways. Like we're fortunate in Dallas because they'll ERCP down to like 1 month, so we started doing the common bile duct exploration, but then it actually started to we had the opposite problem, like it was eating into their numbers, and so they weren't happy. And so what we like, a lot of times they do pick up the patient, they get outside referrals and things like that. So if it comes in through them, the workup is driven through them, and so however they feel is appropriate. But sometimes we get them in the ER, and if I'm doing a gallbladder and I happen to see something or one of the risk factors as you guys described, then yeah, we shoot IOC and we have the choledocoscopes and all the things to do retrieval.
That's a great point. I would just say all of this happens upstream. It's at the initial point of contact, and the ER is traditionally the place where the patient care pathway is won or lost, or is decided with in that respect.
In Little Rock, where I trained, we kind of had the opposite problem. So we had the only endoscopist that would do kids was at the adult hospital, and he would only go down to 5 years old. And so some of the hemonc kids were kind of either had to be transferred or had to wait for stuff. And then and so if you wanted to have him do your ERCP, we had to send a pediatric nurse to go to recover and pre-op, and then so it was a whole sort of production, which me as the fellow got to sort of orchestrate. So I think if you're in that situation, then having this skill set is more than valuable because you can avoid all that.
Just for the sake of time, I think we're going to move on. So if you could hold your questions, comments to the end, that would be awesome.
Okay, I will try to quickly go through the third case so we can have time for questions. But 17-year-old female with obstructive jaundice who presented basically to the emergency department saying she's yellow and itchy. No history of abdominal pain previously, other than being slightly obese. She's otherwise healthy. She did get an abdominal ultrasound that showed choledocholithiasis with intrahepatic ductal dilatation and a common bile duct that's about 1 centimeter approximately, along with a gallstone that was seen in the distal common bile duct. The patient's total bilirubin on admission was 3.7 with a direct bilirubin of 2.9 and a lipase of 35. So the question here is, how would you manage this patient with obstructive jaundice due to choledocholithiasis? Again, the MRCP question, a preoperative ERCP, a laparoscopic cholecystectomy with a possible intraoperative ERCP, IOC, and a postoperative ERCP, or a transcystic common bile duct exploration. I think we've sort of talked about this, and again, in the interest of time, I'll skip this question. But in terms of the review of the literature, just talk about a couple of papers. This is a 2-institution study that looked at a laparoscopic common bile duct exploration in children. 42 children of intermediate or high-risk disease were included in this study, and 24 of those underwent a preoperative ERCP followed by a laparoscopic cholecystectomy. Interestingly, 18 patients underwent an IOC with a transcystic common bile duct exploration in addition to the laparoscopic cholecystectomy. And only 4 of those patients ultimately went on to need an ERCP, 2 for a failed common bile duct exploration and the other 2 for recurrent symptoms. In terms of looking at the outcomes, similar outcomes and similar total procedure times, when you sort of put both the ERCP and laparoscopic cholecystectomy together. However, the laparoscopic common bile duct exploration was associated with decreased costs and decreased length of stay, so 3 versus 6 days. This was sort of shown in a study out of Michigan as well, just because there was a lot of patients that kind of flowed into the diagram. We've sort of split this up where they had 23 patients that underwent an ERCP or an EUS prior to any intervention versus 61 patients that had an IOC first. The similar anesthetic time, again, between these two, but again, this idea of a decreased length of stay was demonstrated in this study as well. Out of the 23 patients that had an ERCP, the range 23 had it, along with the cholecystectomy, anywhere between 0 to 79 days later, subsequent to the ERCP. And of those patients, 3 actually had a negative ERCP, 2 developed postoperative pancreatitis, 2 required re-endoscopy for bleeding post-op, and 2 did require additional ERCP for stone or stent removal. In contrast, the 61 patients that had an IOC first, only 3 failed intraoperative cholangiogram, and those 2, only 2 required an ERCP, whereas 1 was just trended postoperatively with just labs. 37 patients had negative IOC, so those patients underwent to just complete a laparoscopic cholecystectomy. And 21 patients had a positive IOC, and of those 6, a common bile duct exploration was not attempted. And 5 of those did go on to have an ERCP, and again, 1 just had postoperative blood work that was trended, and 15 had a transcystic common bile duct exploration, of which a common bile duct exploration with stone extraction was successful in 7 patients, and 7 more required an ERCP thereafter. So coming back to this case, this is something that I think Lucas will probably be very excited about. So discuss the treatment options with the patient and family, obtained consent to proceed with a laparoscopic possible open cholecystectomy, a cholangiogram, and a possible common bile duct exploration. So we just have some information about how common bile duct exploration is performed, that there's multiple permutations to this depending on equipment that you have available at your institution. So this is Lucas's paper, just looking at just some of the equipment that he likes to use. So typically it's a angiogram catheter or a Fogarty balloon. And this is just goes through the setup. I'll quickly go through this just to give Lucas time to discuss this himself. But again, placing the angiocatheter into transabdominally and then into the cystic duct to perform the IOC. And then if you identify a filling defect, proceeding with administering glucagon and attempting to flush the common bile duct. And again, if the surgeon is comfortable, proceeding with transcystic instrumentation. So the things that are sort of available to you are numerous, from balloon to basket extraction to choledocoscopes to aid in the process. And this is just a wide range between, what some of the things that as surgeons we can do when we intervene on patients during a laparoscopic cholecystectomy, ranging from just completing the cholecystectomy and proceeding to ERCP to using like laser lithotripsy, or we talked a little bit about transcholedochal common bile duct exploration, which I think most would agree would, not proceed with, but that would be an example of something on the other extreme. And again, if your common bile duct exploration is not successful, complete the cholecystectomy and plan for a postoperative ERCP. So in this patient, just proceeded with a transcystic common bile duct exploration. You can sort of see the stone that is at essentially at the sphincter of Oddi with just the wire down and just instrumentation that demonstrates clearance of the stone as well. So this patient did not have a stone on just a completion cholangiogram, completed the laparoscopic cholecystectomy. She was discharged home the subsequent day.
So before we move on to our final abstract, I'm just going to summarize some quick take-home points. First off, children with symptomatic gallstones should be screened for choledocholithiasis with a pre-op ultrasound, and I think we're seeing that blood work, particularly in pediatric patients with choledocholithiasis, is important. Pediatric patients who are intermediate risk should undergo IOC, probably rather than MRCP, because of the increased cost, length of stay, and need for sedation that can be associated with MRI. Patients with a positive IOC can be treated with a postoperative ERCP. That's a completely reasonable option. Transcystic laparoscopic common bile duct exploration is an alternative, but again, only by surgeons who have the necessary equipment, experience, and training. High-risk patients, as we saw, can very reasonably be treated with a preoperative ERCP, but there are centers, as identified in the literature and amongst our attendees here, who are doing intraoperative ERCP. Transcystic laparoscopic common bile duct exploration may be an alternative as well. Access to ARCP remains essential for any pediatric surgeon managing children with choledocholithiasis. I think that's really important. Even when we attempt a transcystic exploration, some of those patients do go on to need a postoperative ERCP, so really important that you have those relationships with your GI colleagues. And I think finally, just emphasizing that choledocholithiasis is a surgical disease. Depending on where you practice, some of these patients may be admitted to the pediatric medical service, maybe pediatric GI, but I think as surgeons, we need to be in the driver's seat so we can have those discussions with family about MRCP or IOC or transcystic exploration. And I think importantly also making sure that they have their gallbladder removed on that admission and not 79 days later as we saw in one of the studies. Thank you very much. I'm going to be turning things over quickly before we do some comments to our next abstract because I do not want to cut off their time. So if we could have Dr. Rauh from Wake Forest Baptist Medical Center, she will be presenting the next abstract, Making Common Duct Exploration Common. Balloon sphincteroplasty as an adjunct to transcystic laparoscopic common bile duct exploration for pediatric surgical patients.
Thank you for the opportunity to share our experience with you today. I have no disclosures. 10% of patients who undergo laparoscopic cholecystectomy will be found to have common bile duct stones. These stones are increasingly being managed by ERCP and lap chole. This results in 2 procedures and oftentimes an increased length of stay. Laparoscopic common bile duct exploration has been shown to be associated with decreased length of stay, decreased cost, and equivalent efficacy and safety profiles as ERCP, as demonstrated by groups like LA Children's, Mott's Children's, and Children's Healthcare of Atlanta, just to name a few. So why isn't this being done more often? Well, there are many perceived barriers, including lack of familiarity with this procedure and perceived complexity. However, there are many ways that LCBDE can be performed, including wire access, nidal baskets, balloons, and choledocoscopes. We've been using balloon sphincteroplasty at our institution, and it's been shown to be safe and effective. This is a QR code that is linked in our presentation that has a helpful video demonstration of the technique that we use. It basically employs basic wire and catheter skills familiar to any pediatric surgeon. Our assertion is that with simplicity, people are more willing to try LCBD at the outset instead of going straight to ERCP. These are the specific tools briefly highlighted in our previous panel, but we like to use a 6 French open-ended ureteral catheter and a floppy-tipped guide wire. This is attached to 2 60cc syringes with a 2E Bors connector. We use our catheter to shoot our initial cholangiogram, and if a stone is remain lodged after vigorous flushing, then you can re-advance this catheter over a guide wire into the duodenum. If after vigorous flushing and glucagon you are still unable to clear the stone, then a non-compliant balloon angioplasty catheter can be advanced over the wire into the duodenum under fluoroscopic guidance. What does this look like in real time? Well, we have a catheter inserted into the cystic duct and our initial cholangiogram is shot. If a stone is remain lodged, the wire is inserted into the duodenum and the balloon advanced over the wire. The balloon is then inflated and retracted to get a tactile sense of where that sphincter is located. This is important because the wire and catheter has an inherent memory that can distort your ductal anatomy that you saw on your initial cholangiogram. The balloon is then deflated and positioned in a way where it's straddling the sphincter. It is then gradually inflated. A waist should be seen, and then will gradually diminish as you inflate your balloon and the sphincter is dilated. The balloon is then deflated and retracted back to the cystic duct and common bile duct junction. It's then partially inflated to create a seal in the common bile duct, and then vigorous flushing can flush the stones through your now dilated sphincter. This is a single-center retrospective study that looked at 15 patients who underwent ERCP with lap chole prior to the implementation of LCBDE at our group. Then 15 patients underwent standard laparoscopic common bile duct exploration, and 15 patients underwent laparoscopic common bile exploration with balloon sphincteroplasty. We define standard LCBDE as wire access into the duodenum, vigorous flushing, and nitinol baskets. No choledocoscopes were used. We looked at several outcomes, including age, race, gender, BMI, operative time, length of stay, and complications. There was no significant difference between age or BMI in the groups, with the age being on average 15 and BMI on average 28. There was an increased operative time for our balloon sphincteroplasty group, but this is important to note that the GI procedure time was not included in these times. Importantly, our ERCP and laparoscopic cholecystectomy group had a significantly longer length of stay when compared to our laparoscopic common bile duct exploration groups. When comparing these LCBDE groups, our balloon sphincteroplasty had a much higher success rate on clearance than with standard techniques alone. The patients who did not succeed with standard techniques underwent postoperative ERCP without complication. The fluoroscopic time did not significantly differ between these groups. However, the fluoro time in the GI suite was unable to be calculated due to machine limitations. Our initial experience suggests that pediatric choledocholithiasis can be safely and successfully managed using LCBDE. LCBDE significantly decreases hospital length of stay and limits additional invasive procedures when compared to the laparoscopic chole and ERCP groups. Balloon sphincteroplasty is the next step on our pathway when simpler flushing techniques are insufficient. And given the initial success with this technique, we have continued using balloon sphincteroplasty at our institution for the surgical management of choledocholithiasis in pediatric patients. Thank you.
Really enjoyed your talk. I love the technical details, so that was fantastic. Just wondering if you could comment maybe on a bird's eye view whether your group has found the balloon sphincteroplasty sort of technically easier than let's say using a choledocoscope or other these more advanced techniques.
Yes, because once you already have the wire access, you're able to just advance this right over your wire, and then just using the inflational device, you're able to just readily employ that. So it's the tools that you already were using, just with one extra thing passed over.
And what size balloon are you usually using to do that
This is an 8 French catheter, and it's usually a 75 centimeter long balloon device that we wind up using the guidelines that are provided with the balloon to advance the to inflate the balloon to the dilation of the common bile duct.
Fantastic.
Yeah, so it's a 5 French device, and it inflates to a profile of 8 millimeters. So it's 4 centimeters long, 8 millimeters wide, or 6, depending on the size of the child.
Comments from the audience? My apologies to those who were cut off, so feel free to step up to the mic if you'd like to ask a question or make a comment.
Very nice presentation. Lucas, I have a question. How did you, and this is coming from somebody who would be a novice in doing this, so please don't take the question the wrong way. Why do we do the initial balloon sphincteroplasty dilation in a retrograde fashion instead of, inflating balloon in the distal common duct and dilating in an antegrade fashion? Is there a reason, or is that just the more comfortable way to do it, or is there more of a risk dilating in an antegrade fashion to injury to the common bile duct and the ampulla? Because when I see my GI colleagues do that, and it's an adult colleague, they're typically doing that in an antegrade fashion rather than a retrograde fashion. And I'm a novice, obviously, watching people do this, but I applaud your efforts, and I think we should all get comfortable with this, because looking at the proxy for all costs in healthcare really is length of stay, and if you're really shaving it from 4 days to 1 day, really, that's a huge win. The other concern would be, obviously, I'd really like to tease out the fluoro time comparing the ERCP and the GI, and if that's significantly different, then that's a little bit different. But if you could comment on how your technical aspects of why you retrograde or antegrade, or maybe that's just you're more comfortable doing it that way. Thank you.
I'll try to tease out so thank you for the question. I'm going to handle this one if you don't mind. The cost of the hospitalization too is an important point. I just want to make one comment about that. When we read a lot of these papers that show cost is no different, et cetera, you're talking about the cost of that individual hospitalization and not the opportunity that's lost to get another patient in that bed for that hospitalization. So if you can reduce length of stay, and that is, so cost should go out the window as a metric. We should look at length of stay because there's all of these hidden incentives and disincentives that are folded into that. So it's a good point. I'm glad you brought that up. With respect to the antegrade versus retrograde dilation, I mean, at the end of the day, you're just trying to get to position that balloon across the sphincter, hopefully in the sweet spot of that balloon's length, and then you slowly dilate up, over 30 seconds, and you hold it there. The mantra is all stones should go forward. And I've certainly messed around with a lot of nitinol baskets. I feel like the fluoro time, I eat up a lot of fluoro time trying to fish those stones under fluoroscopic guidance with a nitinol basket. And this seemed to be a way to use spot images as opposed to fluoro runs to really position and do things in a safe fashion with a guide wire in place. So I don't know if that answers your question, but it's just nice to be able to push stones through a dilated sphincter in the way that they're supposed to enter the GI tract, is my personal thought.
Question for the panel. You have a patient who was admitted overnight and ultrasound shows stone in the bile duct. Do you put them on IV antibiotics because of the presumed likelihood of development of cholangitis while you're waiting for the OR? Asymptomatic, no white count, but yellow, but stones in the duct.
Yeah, this actually has been debated not only for the pediatrics, but for the adults. And really, if you look at that data, unless they're having a fever, unless they're septic appearing and white count, antibiotics are really not indicated.
So just preoperative.
Right.
Okay.
And again, that will come up at the ACS when I talk to you about it a little bit more.
Okay, great.
If you've got a sick patient with obstructive jaundice, then I think ERCP is absolutely the way to go from the front. I mean, like, no bones about it, but that is a very small fraction of the patients that we're seeing.
Right.
Hi, Leo Malvezzi from Miami. I do cholangiograms on everyone. Nobody gets by my OR without the cholangiogram. I'm used to it. It's good for the fellows. And so I often find stones, even when nothing says that there's going to be a stone. My experience, we have a few partners and we're all different. It takes much longer to use a kaleidoscope. It takes much longer to find the thing. It takes much longer for the nurse who's new, who's come from somewhere else, to put it together. And so the little balloons that you can steal from the next door operating room are there at midnight. Anybody can find them. And I've been very lucky. I've never had to cancel. I've never had to stop. So I dilate the sphincter if it's a problem. I switch up to a 5 French catheter, and that can happen at any time of day or night. On the weekends, it can all happen at any point. So I would strongly recommend, I know that the fight about cholangiograms for everyone will never go away, but at least when you find yourself in that situation, to just even try these balloons and catheters. We can all do this because we're doing far, far worse on tiny babies with IV access. So I'd really push for that approach.
Yeah, I just had a quick comment about MRCP. I think the utility of MRCP is when it's the unclear case. You have the patient who sounds like they ought to have choledocholithiasis and you can't find the stone. And so now you're really looking for a different diagnosis. Does this patient have a choledochal cyst, a type 1 or something like that? And so I think that's where MRCP might be useful in our toolbox. But if you already see the stone, then you already know the diagnosis. So it's not adding anything. It's a purely diagnostic test. And so if the diagnosis is in question, then I think the test may be useful. But if you have the diagnosis, then I'm not sure what it's adding to the algorithm.
I think that's a really important comment because with ultrasound, there's a huge variability in terms of the quality of the report you get and the quality of the images. I can think of a patient who I treated very recently where phenotypically they looked like they would have choledocholithiasis, but it was causing great angst within our group because on the initial ultrasound there was no stone seen in the gallbladder. There was just this mildly dilated duct. Now, she did end up having choledocholithiasis, but I think the group was very concerned that we were missing another pathology, and so that's where, the selective use of MRCP, I think, is really important.
Okay, we'd like to thank you all. Oh, do we have one more question? Come on up.
I just wondered if in that preoperative stratification, the low, intermediate, and high, if you guys consider a history of pancreatitis or elevated lipase in that at all?
Yeah, I think that's where the abnormal biochemical findings, so whether that's gallstone pancreatitis without a dilated duct, or elevated GGT and ALT that rapidly resolves, but there's no sign of persistent choledocholithiasis. In my mind, you can use the language low, intermediate, or high, but you could also call intermediate and high transient and persistent choledocholithiasis. These things do happen at a snapshot in time, and that's why we have these frustrating events where, our poor fellows seem to move heaven and earth to organize an ERCP, and then it's negative, which, obviously frustrating for for us, but also really frustrating for the patient to say, oh, we did this, and, yeah, it was totally negative. Yeah, it's a dynamic process for sure. With that, I think I'll close this session. Thank you so much for everyone attending, and enjoy the rest of the meeting.